Welcome back again, everyone. We will start bladder tumor part 12. We will discuss some example of chemotherapy that used in the bladder tumor. We have mitomycin C, and as you see the dose, it is 40 milligram, and this is a good example. And this is the chemical structure of the mitomycin C with NH bond and NH bond between hexo and that's hex singles and fifth singles chemical compounds with 3 NH, NH22 and NH1. So is not FDA approved for intravesical use, unfortunately. So mechanism of action is alkylating agents. It's alkylating agents. Systemic absorption is rare because mitomycin C has a high molecular weight, so systemic absorption is rare. Systemic absorption can cause myelosuppression. So mitomycin, remember MM, the mitomycin lead to myelosuppressions. Mitomycin C is more effective at the urine pH more than TIX. Consider alkalinizations of the urine during the therapy, as we see previously, by sodium bicarbonate 1.3 grams 8 hours at night, and also 30 minutes before instillation of mitomycin. And when the concentration is high, mix mitomycin C in 20 ml of water rather than 40 ml. Usual dose is 40 milligram in 20 ml. Sterile water intravasically. We have a vials of 40 milligram. Mitomycin side effect, contact dermatitis is also common. So we have systemic malabsorption, myelosuppression, but the local we have also contact dermatitis minimized by washing a hand. It is a contact dermatitis of the hand and genitalia. So minimizing this by washing the hands and genitalia after the instillation and after voiding. Irritative voiding symptom. That's irritative voiding symptom frequency, urgency, and nocturia is common. Irritative. This is just to show you that this is the irritative symptoms, and this is the obstructive symptom. Obstructive symptom like hesitancy, incomplete emptyings, intermittency, and weak stream. This is called obstructive symptom. But with mitomycin, common irritative symptom frequency, urgency, nocturia, FUN. This is common with this historic symptoms, as I mentioned, is known as irritative symptom frequency, urgency, nocturia, urge incontinence. And obstructive symptom is not common, but we have irritative symptoms frequency, urgency, nocturia, and urge incontinence common with this. But this just to show you that what is the difference between irritative symptoms and obstructive symptom, which is called voiding symptom, weak stream, hesitancy, strainings, intermittent stream and dribbling, overflow, incontinence, chronic urinary retention. Another, this is the side effect also, soreness, pain and discomfort in the bladders, skin rash, contact dermatitis, itching, feeling of shortness of breath, with and fever, shivers, or feeling dizzy or unwell in any of the allergic reaction. We will come to another one is known as gemcitabine. The gemcitabine, we have example of gemcitabine, 1 gram, for example, or we have 200 milligram of gemcitabine. This is the chemical structure of this, contain only NH2. So it is not FDA approved for intravesical use. Mechanism of action is cytosine, cytosine analog, an antimetabolite that get in incorporated into the DNA, where it inhibits further DNA synthesis and cause death of the cell. It is actually mechanism of action is cytosine analog, an antimetabolite that gets incorporated into the DNA, which will inhibit the the further DNA synthesis and cause cell death. Systemic absorption is rare because gemcitabine has a high molecular weight, and systemic absorption can cause myelosuppression as well as mitomycin C. Usual dose for post-operative instillation is 2000 milligram or 2 gram in 100 ml. In this picture here, we see that we have 1 gram. So we have 1 gram, this is in 50 ml, and 200 in 100, 2000 in 100 ml normal saline intravasically for induction or maintenance. 2000 milligram in 50 to 100 ml of normal saline intravasically. The vial, as you see, it is 1 gram. As you see, we have a vial of 1 gram. So 1 gram vials, it's actually, we need 2 of these vials to dilute it with 100 ml, 50 to 100 ml, and inject it through the catheter intravasically. Gemcitabine side effect, dysuria, urgency, frequency, and hematuria. Okay, that's dysuria, urgency, frequency, and hematuria. We'll come to another drug is known as Thiotuba. This Thiotuba here, as you see, this is a good example for Thiotuba. We have a vial of 15 milligram, and also we have Thiotuba vial of 100 milligram. So we'll use Thiotuba 15 milligram, and this is the chemical structure. FDA approved for TA, T1, and CIS bladder cancer. This is Thiotuba. Mechanism of action, it's also alkylating agent. It's alkylating agent like other alkylating agent described. We described it briefly. Therapeutic dose or therapeutic course 60 milligram in 3 to 6 ml of sodium chloride instilled intravasically each week for 6 weeks. Each week for 6 weeks, it is 60 milligram in 30 to 60 ml of normal saline or of sodium chloride. Therapy is often continued with a single instillation each month for 1 year. This is the therapy as maintenance. But the induction is 6 dose. It's actually 6 milligram in 30 ml. This is each week for 6 weeks as induction. And then we come to the maintenance. It is actually each month for 1 year. Okay. Systemic absorption may occur when Thiotuba is given intravenously because of its lower molecular weight. So the molecular weight here is lower compared with what we call it here, what we call it gemcitabine. Gemcitabine molecular weight is high. Okay, so gemcitabine molecular weight is high. It leads to myelosuppression, but Thiotuba have a low molecular weight. So the side effect from the Thiotuba systemic that might occur when given intravasically because of its lower molecular weight. Systemic absorption can lead also to myelosuppression. We will check CBC, and this must be done before instillation. This is Thiotuba side effect, myelosuppression in 10% of the patient, and irritative voiding symptoms. So here in the Thiotuba, we have irritative voiding symptoms that include frequency, urgency, nocturia, and urge incontinence. Irritative symptoms is also occur as well as in the patient with mitomycin C, FUNU. We will come to the last one, is known as ibuprofen. Ibuprofen, that is of the dose of 10 milligram or 50 milligram. We have two concentration, 50 milligram and 10 milligram. This is the chemical structure. It's contain NH2, only one NH2. Is not FDA approved for intravesical use. Ibuprofen is an anthracycline. It's known as anthracycline, and mechanism of action is intercalating agent. Intercalating agents, and systemic absorption is rare because ibuprofen has high molecular weight, like what we call gemcitabine. We speak about the gemcitabine. As you see, the gemcitabine here, this is the gemcitabine, have high molecular weight, but the Thiotuba have low molecular weight, so systemic absorption might occur and systemic side effect might occur. Okay, so ibuprofen have systemic absorption is rare because ibuprofen have high molecular weight. Systemic absorption can cause myelosuppressions. Usual dose is 40 to 100 milligram in 40 to 100 ml of sterile normal saline instillated intravasically, and the vial, as we see previously, we have 10 and 50 milligram. So here in the bladder cancer, we will use 50 milligram. All right, so this is the usual dose of 400 to 100 milligram. This is actually in 400 to 100 ml of sterile normal saline intravasically. This is ibuprofen's side effect includes irritative symptoms that include frequency, urgency, nocturia, and urge incontinence. Irritative symptoms occur with ibuprofen, and also irritative symptoms occur with Ciotiba, and also irritative symptoms occur with mitomycin. This is a side effect, okay? With mitomycin, we have contact dermatitis. It's actually common. We have contact dermatitis, and we have also myelosuppression with gemcitabine, which is actually high molecular weight. Myelosuppression also can occur as well as mitomycin. And the symptoms that side effects are different from all. It is actually gemcitabine side effect include dysuria, urgency, frequency, hematuria. So we have some irritative symptoms that include urgency and frequency, but we have dysuria and hematuria can occur with gemcitabine. Okay. This is side effect. We'll come to the last one here, varobasin of this session. Varobasin is known as Valstar. The Valstar, as you see, is a Valstar. It's actually, this is a trade TM. It is only for intravesical use only, not IM, not IV. Okay, so it's intravesical. It's known as varobasin. Varobasin intravesical solution. This is a chemical structure. Is contained NH only. So it's FDA approved. Let us skip this. It is FDA approved. Okay, for the treatment of patients with CIS with or without papillary tumor that is refractory to the BCG and who are not candidate for radical cystectomy. All visible stage TA, T1 papillary tumor should be resected before the treatment. Varobasin is an anthracycline. Mechanism of action is intercalating agents, and systemic absorption is rare. Varobacins have high molecular weight as gemcitabine. Systemic absorption can lead to myelosuppression. I would like to say for you that the gemcitabine, it's actually varobasin is FDA approved. Okay, then we have another FDA approved one. This is Ciotiba. Ciotiba is also FDA approved. Okay, but all other medication is not FDA approved. It starts from mitomycin is not FDA approved, and also gemcitabine. Gemcitabine here is not FDA approved for intravesical use. And also we have the last one here, ibuprofen. Ibuprofen is also not FDA approved. Okay, that's all about the varobasin. Okay, varobasin therapeutic dose, we have 800 milligram, 20 ml in 55 ml of sterile normal saline. It's 800 in 55 ml of normal saline instillated intravesically each week for 6 weeks. The vial dose is 200. So we'll use, this is the vial dose as you see here. The vial dose is 200. You use 4 of this. It's actually with 55 ml of sterile normal saline, and this is actually instillated intravesically. Okay, so complete response rates is 18% at 6 months of follow-up. And this is the varobasin side effect. As I mentioned, varobasin is also lead to irritative symptom, frequency, urgency, nocturia, and urge incontinence. Thank you very much. This is the end of the lecture.